Now we have Professor Siddharth Jhunjhunwala from IISc Bangalore. He's Associate Professor, and it's my special privilege because he's been my supervisor at for my PhD thesis at IISc Bangalore. Thank you, Siddharth. We'll start now.
Thank you, Sushmita, and thank you to the Pancreas 2025 team. I'm going to talk about something slightly different, about inflammation in the context of type 2 diabetes, especially in animal models of research. And we think that this can be applied to pancreatitis and other pancreatic diseases. So let me get right into it. Right, this is the basic question that we had about a few years ago. This was one of the first reports from Italy. When you had COVID-19, people with diabetes were dying, had higher mortality, higher morbidity. Why was that the case? That remains a key question, although there are many theories and many good examples of why that's happening. We still don't fully understand the details of why this is true. If you go back in the literature, you will see that in the 1970s and 80s, this was a key question for influenza too. And that's why in the 1990s, there was this recommendation of a vaccination against flu, especially for older individuals and those with comorbidities such as diabetes, because individuals with diabetes tend to have more severe infection, higher mortality after flu infection, with flu. This sort of remains a key question in the field, and there are not very good animal models to test some of the theories of why this might be happening, the mechanisms of why there is higher mortality. And that's something that we were trying to do, but with a very different angle, trying to engineer new approaches for testing in animal models. Right? So this is where we started about 10 years ago with this idea that diabetes is an inflammatory disease at some level, and there's a higher risk of mortality when there's a second inflammatory stimulus. So diabetes being the first inflammatory stimulus, and then when you add a second one, whether it's COVID or influenza or surgery or another infection or injury, you get worse outcomes, right? How do you now replicate that in an animal model for us to ask basic questions, test new drugs and so on? That was the key feature. We went back to this general idea that we think of as an engineer. With chronic inflammation or with diseases such as diabetes, you live a new normal life. But if you add now a serious inflammatory event, you have increased morbidity and mortality. Can we do this in a mouse model? For this, we chose to use type 2 diabetic mouse model. Sorry, I'll skip this. The basic idea being that this particular mouse replicates some of the features of type 2 diabetes in humans. It is obese. It has high blood sugar, and this high blood sugar can be controlled by drugs such as metformin. So somewhat related, not exactly. And this is work done by two PhD students in my laboratory, Jayashree and Vinod. So basically what we did was we measured a variety of different things in these mice, and I'm only showing you a piece of the data, this specifically with respect to neutrophils. So normally in humans we have about 60-70% of the cells, 50 to 70% of the cells being neutrophils in circulation, but in mice it's about 20%. Only in the diabetic mouse do you have this increase to 30%. And among these, the immature neutrophils are much higher in number. They're about double or triple the amount in percentage. And in terms of actual numbers per microliter of blood, there's about a 10-fold increase in immature neutrophils. This was our first observation, I would say, that there are changes in immune cells. There are some changes in monocytes, not as many changes in T and B cells in type 2 diabetes in this specific mouse model. So we looked at the neutrophil function specifically. They are functionally altered. They produce, the diabetic mice, the neutrophils in the diabetic mice produce a larger amount of ROS, reactive oxygen species, in baseline conditions and upon activation. That's almost threefold higher. They also have higher amounts of DNA release, that is netosis, a measure of netosis, almost doubling of the amount of netosis. But in contrast to the other two features, they are less phagocytic. So some functions of neutrophils seem to go up in diabetic mice, some functions come down. Surprising, and we have human data. I just don't have the time to show this. This is exactly what happens in type 2 diabetic patients compared to healthy controls when we do it in a human study. Peripheral neutrophils have higher ROS, higher netosis capacity, lower phagocytosis. So this gave us an idea that, okay, this mouse model seems to behave very much like type 2 diabetic patients, at least in this context. So what we asked was, can this now be used as a model to study the second injury? So, and the second injury, instead of an infection which causes serious damage that was from other factors, we just did a sterile lung injury, which is well known in the animal literature, which is giving lipopolysaccharide intratracheally. And if you do that, we can assess lung health similar to what would be done in humans. And this is a regular histology. As you can see, this is the wild type animal model. You're starting to see the alveoli. You definitely see more cells in the histology slide, but it's much highly infiltrated with cells in the knockout diabetic mouse model. If you now score this using a pathologist, we scored these clinical pathologists, the injury score is about twofold higher, and that's primarily because neutrophils are present in interstitium, there's hyaline membrane and other things that are coming into place, right? We also can measure the Young's modulus, which is the stiffness of the lung, and we show that at the early stages, this is only 4 weeks, the stiffness reduces, which basically means the mouse is not able to breathe as well because it's not able to expand and contract as well. So this is sort of the same thing that happens in humans when they have severe infection. But the big question here is that diabetes causes some 10 different changes, immature neutrophils being one of them that we have studied. How can we link it to lung injury, right? So for that, we should avoid all these other changes and only change immature neutrophils. How do we do that? And that's the mouse model that we created in our lab. We developed a model, that is a PhD student by lab, Alkesh, who is now graduated, basically using biomaterials. These biomaterials are sterile materials that do not have any other features that will cause activation of immune responses except for the innate immune responses and specifically only neutrophils and monocytes. So what we show using various flow cytometry means, and I'm not going to go into the details, is the same thing. The number of neutrophils in circulation increases similar to type 2 diabetes in this mouse model. These are wild type mice with diabetic implants. Nothing else is changing in these mice. We've studied them. Immature neutrophils are much higher, both in terms of percentages and in terms of numbers, about 100-fold increase to immature neutrophils. To confirm that nothing else is changing, before that, we also studied the same sort of changes in function of these neutrophils, and without belaboring the point, this mouse model in orange, which is the chitosan biomaterial implant, is exactly similar to the knockout diabetic mouse model, suggesting that we have a model where the neutrophils are changing the same way. Right? To confirm nothing else is changing, we did single cell RNA sequencing of cells from these mice, and we studied various immune cells that were changing. And to quickly summarize a large amount of data, we basically saw that 95% of the differentially expressed genes were among the neutrophils and monocytes. The monocytes are consequent of neutrophils. Almost nothing is changing among the T and B cells, and we don't see any major changes in endothelial cells, in the epithelial cells, in the alveolar cells that line the lung tissue, and also other cells in circulation. Right? We confirmed this with only looking at the neutrophils in the single cell RNA sequencing, and the neutrophils definitely show a higher ROS production capacity, higher neutrophil extracellular trap production capacity. Right, so we have a model now, basically a biomaterial implantation model that results in increased circulation of immature neutrophils. Now, could this be used to understand the increased immunopathology that we observe in diabetic animals and potentially in patients? Right? So we again went to the second model. So the first inflammation is the biomaterial implant. On top of it, now we inject LPS or intratracheally inject LPS into the lung, and we do a bunch of different analyses. We're only going to talk about the lung damage as a final outcome or scoring. And you will see that our lung pathology scores at day 14 and day 28 are much higher. More neutrophils are infiltrated. This is neutrophils in interstitium, neutrophils in alveolar space, and the hyaline membrane that I talked about before is also increased at day 28, again replicating what happens in diabetic mice. Right? So assessment of lung damage using the atomic force microscopy, similar results. We can reduce the chitosan implantation followed by LPS reduces the stiffness of the lungs at day 14 and day 28. But quickly, because I'm short of time, I'm going to take you through, okay, so we know it's correlating. How do we know it's causing? Right? Causation can be potentially proved by suppressing the immature neutrophil function or their numbers. We cannot suppress their numbers in the mouse model, it's very difficult, but we can suppress their function. Anti-GCSF administration is supposed to suppress immature neutrophil function. This has been shown by others. And Siddharth, which is used in the clinic as an elastase inhibitor, is also known to block immature neutrophil elastase activity. And so we use these two drugs in the mouse model. and show that the acute lung injury score in that same model where we implant biomaterials, then we have lung injury and we inject civil stat, so it's a complicated model, we can reduce the injury in the lung back to normal levels compared to no drug treatment. We can also do the same with antibodies against GCSF and IL-1 beta. IL-1 beta is downstream of GCSF, but not TNF alpha. TNF alpha is increased in inflammation, but not in this particular pathway. So we show that this particular pathway is what is important. It is the GCSF, IL-1 beta and elastase pathway that seems to play a very important role. And we can restore lung stiffness also with the civil stat treatment. Right? So I'll quickly summarize here and end the talk. Basically, neutrophils are produced in the bone marrow and they come out into circulation. But if you have an inflammation, whether it's inflammation because of injury, diabetes or pancreatitis or something else, you have this left shift with clinicians see, which is basically banned cells, immature neutrophils coming into circulation. If you add a second inflammatory stimulus, what our data shows, at least in the animal model, and we're now testing it in some human samples, the immature neutrophils drive pathology, immunopathology. They drive the inflammatory pathology, causing greater lung injury. And we can block this using civil stat and anti-GCSF. And we're now working out whether there are other drug regimens that might work in this pathway. I'll stop here. This work was funded by India Alliance, and thanks to Professor Nagasuma Chandra and her student Ranjita for all the help in analysis of data. And all our clinical scoring was done by a pathologist in Bangalore, Professor Kalpana. This is also funded by the Indian Institute of Science. I'll leave you with this figure. Thank you for your time.
Thank you, Siddharth. As always, finished on time, very ahead of time.
Nice talk. So, do you see similar kind of changes in, like, when in case of pancreatic cancer, like in immunodeprivation, is there any like skew towards the neutrophil?
We have not yet tested pancreatic cancer, but that is the plan. So we are now starting with an acute pancreatitis model, thanks to Dr. Dhar. We are discussing how to do that in the mouse. And there is also another collaborator who wants to test it in a pancreatic cancer cell line model that we have, PANC1, PANC1. But we have not tested it yet. But the expectation is that it should be similar.
Is there any report, similar kind of?
Sorry?
Is there any similar kind of report?
No, nobody else has done it. This is sort of the first time, I think, I have not seen anything in the literature, but if you find something, please let me know. Yeah. That we have this particular model, we've shown that immature neutrophils are important. We've done this in another tumor model, in a breast cancer model, but we've not done it in pancreatic cancer.
Thank you.